Like to introduce Professor A.K. Agarwal. You have all, most of you have already seen him in the first induction meeting. Those of you who had attended, he is also the program coordinator for this program. So, Dr. Anupam?
We come straight to difficult diagnosis. So again, I told you at the beginning that my aim here is not to tell you everything about diagnosis, but maybe I'll be showing you some cases which created a little bit of difficulty in diagnosis. Difficult diagnosis can be a misperception, a misinterpretation, or incomplete diagnostic examination. See, once we have gone through the history, we've looked for the etiology, percussion, and all things have been done. Then whatever your findings are, if they are not perceived in the right manner, it can lead to a wrong diagnosis. If whatever the clinical signs and symptoms you found are misinterpreted, then also it can lead to a difficult diagnosis, and otherwise, or if you have done an incomplete diagnostic examination. Let us take a case of misperception. Now see, this is this case is root canal treated, the upper 6, right? Now there was a thermal sensitivity in an endodontically treated tooth. Whenever it is sensitive to cold in a root canal treated tooth, we all the time put ourselves back and start thinking, oh no, it is not possible, this tooth is root canal, how can it be sensitive to cold, there is no nerve inside a tooth. So this is basically to do with a misperception. As I told you, this patient came with the sensitive to cold, and you say no, it is not possible, it has been root canal treated, how can it be sensitive to cold? At this point, I like to add and stress onto it is never ever antagonize with the patient. Whatever a patient is complaining, there has to be a truth into it. Most of the time, if that truth is something which you can treat it, and if you can't, be a part of it. But never antagonize ki no, it is not possible that you are having like this, you are having like this. Try to find out as to what he is saying, try to find out at a biological and cell to cell level as to what is happening and what is the problem he is facing, and try to interpret it or perceive it accordingly, right? So for example, in this case, this is a case of misperception, and if you see this tooth, if you see this X-ray clearly, then you find that there are 3 canals, no doubt, but there is a black radiolucency, a black radiolucent line all around it here. Whenever you find any radiolucent line around the GP filling, there are 2-3 reasons. One thing is either the canal has not been filled in, condensed in properly, or it can be a shadow of the root wall, or third, it can be a missed canal, right? So in this case, it happened to be a missed canal which is to be treated. Now this same case here. Now this is another case. Again, this mesiobuccal canal is like this, and this mesiobuccal canal, when you see it, it has got 2 roots. Now mesiobuccal canal also, I like to add it here. Sometime again study a extracted tooth, extracted upper molar, and then you will find that the mesiobuccal root is quite broad, and that's why there is always a chance to have the second canal into this MB2, which we call it. And most of the times, if you're keen to find it, I have seen you always find it. And if you're not keen to find it, you are happy with the 3 canals, but then the problems can come on like this. Now this tooth, it has got an accessory canal. Again, it's a premolar. Everybody thinks it's a simple tooth to treat. I find the anteriors are more difficult to treat than the posteriors. Maybe because our SS opening is limited. The SS opening length is limited, and second thing which is more important is that we again take it very casually. So that was accessory root. Now that was an accessory canal in the premolar, right? Whenever we find that at a particular point you are not able to reach till the apex, and you find that there is an obstruction, or if you find that all of a sudden the canal has become very thin, then you should suspect about an accessory canal. Now this accessory root, this usually happens in upper second molars. Many times the X-rays are like that you tend to miss it, and sometimes there is no there is no third route at all, and these things can also lead to our difficulty in diagnosis and treatment planning. That was perception
So
when we
before
were
we
not.
go ahead, I would also like Dr. Tarun to interact and tell us whether, from his experience, and from the experience he has also been guiding various other people and training other people going in for trainings. What are your ideas about this misdiagnosis and misperceptions? Are they very common? And if they are common, in which areas do you feel they are very common? And how to overcome them? I mean, how one should be very, one should be aware that they are there, and then how one can take precaution that one doesn't get into this kind of a thing, and one is able to do the correct diagnosis. Because naturally, the most common reason why a patient will come to a dentist is pain, and if even after a root canal a patient doesn't become pain free, then naturally the faith is shaken, with the dentist. So how to get away with this misdiagnosis and maybe misperception?
I think diagnosis is a major problem and a very important one. Like Dr. Anupam started with his presentation, that most of the people don't try to reach to a diagnosis. They just ask the symptom and start the treatment. So I think it should be a series of questions, or rather a very patient listening to the patient, what he is trying to say, and then you reach a conclusion that this is the problem, why the patient is here, and then you make a treatment plan and then execute the plan. So I think it is a whole series which has to be followed, and if we just try to rush in our treatment protocol and don't follow what is mentioned in the textbooks, we are likely to go into a lot of problems of misdiagnosis and misinterpretation. It's like when we were in colleges, we used to have a case history per forma, which used to be filled up as soon as the patient enters the department, and by the time you finish all that and do all the examination, record all the history taking, it was automatic that you reach to a diagnosis after doing certain tests if you need so in between. Now when people leave the college and enter the private clinics, I have seen that not even 50% of the people have records for their patient, and people who just have record do it very casually. They do not record what the patient is trying to tell them. So I think that is the basic problem, that you don't give sufficient time to hear to the patient, and obviously if you are not listening properly to the patient, it is something different that the patient is saying, and it is something different that you are interpreting, and most of the time you end up doing a different treatment plan. So those are the problems which we commonly encounter in our day-to-day practice, and I think in designing this program, it is a beautiful opportunity for everyone to go back to the basics, go back to the college and relearn the same things that were done a couple of years back, for some many years back, and again go into the same training schedule and try to learn things again from the beginning and implement them in a different way.
I think that's a very, very important thing. That is why what we have done is that we have prepared the logbook, in which you have to enter, in a stepwise manner whatever you have done, and that is why, as the call from Chennai, I am insisting that we must have the contact sessions, because in this you are again, you are relearning what you have actually forgotten, that you have to go stepwise, you have to go at each point so that you do not miss. So it's very important that you meticulously do all the activities, and I think that is also very important that once you come to the practical sessions, you must simultaneously also go through your theory modules. We are not having any theory lecturing in the contact sessions. However, if you go through your theory modules simultaneously while you are doing your practical contact sessions, then whatever doubts you have, whatever things are not clear, can be made clear from the counselor, and you again you have an idea, like Dr. Anupam is saying that accessory canals may be present. So if you are not aware of it, naturally you don't look for it. But if you are aware about it in the theory, then naturally you question, you keep it in mind, you question about it, and you find that is the reason why the patient has been misdiagnosed, or has not been properly given the proper treatment.
We have also tried to synchronize all the theory and all the practicals, so that before you reach the college for a particular contact session, you have read about the steps of what you are going to do, and also the theory which goes behind that same practical session.
So after misperception, we were talking about misinterpretation. Interpretation is the interpretation in sensitivity. Whenever a person comes and the person is complaining of sensitivity to hot, immediately we start to pick up a syringe and then add little warm water into it and then sprinkle that warm water onto the teeth. Many times the sensitivity comes after 10 to 15 seconds, not immediately. But in an effort to find out as to which tooth is sensitive to hot, you have sprinkled almost all of that in that particular arch. So it's always that after, maybe in some cases you find that the sensitivity comes up after 10 to 15 seconds. So if you have to find out a particular tooth which is sensitive to hot in a place where there are maybe 14 teeth on one arch, then it is always advisable to first sprinkle it, wait for 10 seconds and then sprinkle the other one. And always sprinkle the most distal tooth first, and always sprinkle the lower arch first, then the upper arch. Same is with the pain on biting. Pain on biting can be ruled out by asking a person to firmly close down onto a cotton bud, and then the lateral excursions will produce more closely the movements of mastication. So pain on biting will be more evident whenever a person is asked to close the jaws with a lateral excursion onto them. Trauma from occlusion. This is a particular case which has been treated twice for a root canal treatment, thinking all the time that my canals are infected, but it was a trauma from occlusion which was causing all the damage. Always look into this trauma from occlusion also. All these things are into the diagnosis only. Before interpreting as to what is going to happen, it is important to keep the things right. And keep the spirit, right? The day is yours. This is a small, I remember once I went to a place in Sikkim where they were, it was very long. It was approximately 2 kilometers, and at every 500 meters there was a board like this: keep up the spirit, the day is yours, because you are soon going to reach the place which you are going to visit. Now, incomplete diagnostic examination, not only the tooth, the periodontal examination, the radiographs and the thermal test sprinkling technique. That same thing which I said, if a person is complaining of hot, sprinkle hot. If he is complaining of cold, sprinkle cold, and you will be able to reach to the diagnosis in a faster manner. Whenever I see a case like this where 4 or 5 of all the teeth have been root canaled, I always think that this is a case of misdiagnosis. It can't be that it's only one tooth which was bothering. For example, see in this radiograph, it appears that maybe something started in the central incisors, but then the one central incisor, and then the lateral incisor, then the other central incisor, then the lateral incisor. So whenever in an arch you find that there are 4 teeth which have been root canal, 3 teeth have been root canal, that is again a lack of proper diagnosis. And it is usually, you will find whatever the complaint of the patient is, it's not more than 1 or 2 teeth which are really bothering and creating a havoc by radiating the pain to the upper or the lower teeth. What do you say, Dr. Tarun?
Yeah, I think again listening to the patient is very important, because what the patient tells you, it must be registered well in your heart and mind. And then again, repetition of the symptoms what the patient says. For example, if the patient is sensitive to hot, try and test with something hot. If the patient is saying it's sensitive to cold, try and test something cold onto the tooth. And again, even if you can't diagnose thing in one go, it is better to recall the patient again and test the things again, rather than doing a very radical treatment and treating 4 teeth altogether and not finding one tooth which is giving trouble. So not necessarily you have to do everything in one go. Maybe you test it once and test it another day, and then start your proper treatment for the patient.
Thank you, Dr. Tarun. Now see, this is another case which is a beautiful case. This patient came with a pain in the pain on pressing the apex of the upper premolar area, right? So when you took an X-ray, you find it, okay, this seems to be a 6 which is involved here, and this is giving pain. Fine. He says, okay, you treated the tooth. After 6 months, 8 months, he again came with the pain in the same area. You took the X-ray, and then you find there is nothing. Somehow you thought that maybe let me see that this is a premolar here, maybe something is wrong here. This is a crown here without any root canal. You took an X-ray and see what you found, that there is another tooth lying here. And then you found that there is an impacted canine which was causing all the trouble. rather than this tooth may have been involved, but now treating this tooth, had we have only this X-ray with us, we would have thought that it is maybe a failing root canal or something like this. You could have treated it, retreated it, but whenever you are taking one case at a time, just have a radiograph of one or two teeth adjoining each other also to find out if it is there. Now this is a bridge here, so maybe this was a missing tooth here. Again, here we missed the history. We never asked as to why the bridge was placed here. So there was a deciduous canine here which fell off. Patient went to the dentist, he put a bridge here, fine, finished. Never took an X-ray, never told the patient that there is a permanent canine which is lying inside. And then he came again for this tooth, this was treated, but then the pain persist, and then you found that there is another tooth which is lying here like this, canine. So this is again improper diagnosis, maybe because of not able to take this. So again we come to the radiographic interpretations now. 50% radiographic interpretation is different in every person who sees the X-ray. They have come up with a different 50% of the cases. It is a documented study that 50% among observers the radiographic interpretation is different, and the parameters are often manipulated to meet the needs of the professionals. This is very sad part of it, that usually if it is a periodontist who is seeing an X-ray, he will always find a pocket there or some crystal bone loss there. If an endodontist is seeing it, his eyes goes to the distance between the pulp chamber and the occlusal wall, or he looks for some proximal caries. And if an oral surgeon sees it, he always look at the root first and then say, okay, fine, it is like this, it is like this. So again, this is all the part of a profession, but yes, usually it is very important to have a good radiographic interpretation, and not always you find that any tooth which is infected has got radiolucency at the base. And it is also true that once a root canal has been completed and you still find a radiolucency at the base of it after 1 year or 2 years, or in your follow-up checkups, that does not mean that something is really developing there, because it is important to see the pre-operative radiograph to really judge whether that radiolucency is increasing or decreasing, right? Changes are not evident until sufficient erosion of the cortical plate is done. The assessment of root anatomy is very important, and most of us are really going to see it. That is why the section cutting has been added into it, because it appeared to be such a small exercise, but to give you a feel of the root anatomy as to how the pulp chamber is, how the root canal chamber is, and what is the various flows of the pulp chamber at the cervical portion, middle third and the coronal third, that the assessment of root anatomy has been added onto it. There was one study that if you find that the root canal space is not exactly in the center of the tooth, then you must all the time look for some other extra canal into it. Usually root canal anatomy is very symmetrical. Nature, everything here has been made very symmetrically. If you find that your distal canal is going more towards the lingual side, always look for it. It is possible that there is a necessary, or there is another canal which is there on the distal aspect only, which is there on the buccal side. Then the dimensions of the canals on the mesial aspect and on the distal aspect, especially in second molars, for example, lower second molars, whether there are 2 canals, 1 canal or 3 canal, sometimes can be interpreted by the time your first file goes into the canal. If you find that first file going to the canal on the distal side is very broad and on the mesial side is very small, it is possible that there is another canal in the mesial side. And similarly, and especially lower first molars with the distal canal which is not going towards the buccal side or in the center, which is only going towards the lingual side, always look for another canal on the buccal side. And rapid change in apical 1/3 of the canal which ends on the buccal or the lingual surfaces of the tooth is very common. You always find that this canal is little bit short, or I am not able to reach the apex, because the canal is not ending at the apex. It is ending at the buccal or the lingual side, lingual surface of the tooth. This is an example of it. See, here it appears that my distal canal is small, even the apex locator is also not giving that right feeling, because this is a very small canal which ends onto the buccal side of the tooth. And on your observation you find that it is something like this here. So change in the density at the apex is very important. If the change in the density, for example, if you see the other X-ray which is here, you find that this such a big broad canal goes and all of a sudden it fades from here. When it fades from here, it is either dividing into 2, right? Most of the time it is divided into two. Otherwise, it should be straight till the apex. In this case, it is not going straight till the apex. It is ending up here at the buccal wall. All these things can be interpreted on an X-ray, good quality X-ray, and IOP X-rays are good enough for it. These things don't come up much on the OPGs or different other ways of the X-rays, right? Using a gutta percha point to find out which the sinus is involved, wherever there is a sinus opening, and you put a gutta percha point into it, and you find that there is a particular area where the gutta percha point is going, and that usually localizes onto the tooth which is responsible for that infection in that area. SS opening is again is very important. Now, all the books usually are all ideal cases. All ideal cases. They will always tell you where to start your round burr, where to go to it, how deep to go. But when it comes to the practice or into the clinical work, you will find that all the cases are different. Sometimes you find that there is so much of decay onto the distal aspect of a tooth that if you try to open it from the center and extend it onto the mesial aspect, you find that it's only that buccal, the lingual walls are left, and hardly the tooth wall is left. That usually can create a fractures in the teeth. The cervical erosions in the premolars, usually in 4 and 5 and lower interiors, you find that the cervical erosion is so big that it has involved the pulp, and then to open the tooth from in a conventional manner from the center of the tooth onto the lingual aspect, you go into the center middle fossa, and then you start to direct your burr towards the buccal side. You usually find that a lot of tooth structure is lost. Sometimes you have to tailor make the cervical erosions as an opening. But you have to keep your basics absolutely right, that you have to get a straight apex, straight to the, your SS opening should be straight to the apex, right? So incisal surface of attrition teeth, if you find that there is so much of attrition onto the incisor teeth, why to go for a conventional root canal opening of the incisal teeth from the lingual aspect? Think about why not use the incisal surface. Because the idea of opening, SS opening, making it from the lingual aspect was that was the closest distance between the pulp chamber wall, between the roof of the pulp chamber and the outer wall of the tooth. When it becomes a incisal surface, the area on the surface in that area is so much of thinned up that immediately you can start reaching to the apex. But always make it a point that you are able to reach to the apex without any obstructions, without any bends, without even moving your head here and there or fingers here and there. It should be the straight approach to the apex, but you can always tailor make it according to your basics, thinking the stability and functionality of the tooth in the mind, and keeping the tooth walls intact, approximately 2 millimeters from all the sides.
Dr. Tarun, would you also like to suggest certain things for access opening, some tips?
I think one of the key statement is that proper access is the key to success, because if you don't start something properly, it is very difficult to go a proper way and finish the same thing properly. So if your access principles are clear, if you see the X-ray properly, the orientation of crown to the root, the orientation of crown to root on the X-ray, how the angulation of the crown is inside the mouth, how much of the tooth surface is decayed, and what is the problem, why you are doing the root canal treatment. So those factors play a key role in how to design your proper access cavity. And if you have the proper X-ray, know the pulp anatomy properly, and see how the anatomy of the crown is, then I think it would be easier to mentally visualize how our proper access opening should be. For example, it has to be ovoid in lower anteriors, triangular in upper anteriors, rhomboidal in the posterior molar teeth. So our basics have to be clear, and then it is a matter of application and slight modification from case to case basis. And if we have the proper image in our mind, I think it is not very difficult how to design and proceed from there.
And see, this is a case of what he was talking about, angle of crown to root on a tooth in a dental arch. Now see the angulation of this tooth, right? And trying to open it right straight, thinking that it is a straight, could have caused a lot of damage to the tooth. So it is very important to find out the arch of the tooth. Maybe whenever you are making an SS opening, just retract the cheek little bit and see that you are going along the long axis of the tooth. See, this is another case where the angulation of the tooth was very different, and then you see that where the canals are going towards and how the tooth has been placed on this side. This is another case where the angle of the canal to the root, the tooth was opened like this, and then it was perforated in this area, and then it was realized, oh, where are it going? So you make the angulation of the tooth right, and then you are able to finish it. And in this particular X-ray, I really see what is there at the apex. There are so many lateral canals, accessory canals all around it, and a close-up of this really appears very beautiful, because then there are 4 or 5 areas from where this filler has seeped out. Then 5 canals in mandibular first molar. It's very easy to miss the canals. Now in this you see there was 4, and then you find out that there was a 5th as well. These are the common errors which happen during SS opening. Again, whenever you are doing an SS opening, I usually see people picking up the first burr they get a sight on their dental chair, whether it is inverted, whether it's a tapered fissure or it is a straight fissure. But you don't get the feel of a drop into the pulp chamber unless and until it is a round burr, and round burr also as thin as possible. So use of round and inverted cone burrs is a very basic in opening any of. Maybe we are champions in opening the SS in opening the canals or entering into the tooth chamber and removing the pulp chamber. But still, the basic lies into the round and the inverted cone burrs. And we must realize that we are doing that root canal treatment in that particular tooth if it is because of caries only. The real causative organisms are in the caries, so remove all the caries. I've seen very good obturated, well obturated canals with a distal caries still intact, and then you think that okay, maybe when we have to do the crown cutting at the time we are going to do it, but no, that will always be a site of bacterial and salivary contamination, and which can always lead to the failures, because the saliva is definitely going to contaminate from there. So the cause due to which the root canal is needed, that cause should be attended to first, and if it is caries, at least remove all the caries first at the periphery. Before entering into the pulp chamber, all the caries from all the sides should be over, because they can all the time fall into the pulp chamber and again contaminate it. Feeling the drop is very important. You must know where to stop the round burr and pick up your inverted cone to flare up all the pulp roof. Switching to inverted cone, the movement also changes. It becomes more outward and outstrokes. So in this basics, this dental map is again very important, very important. Don't ever enter into the canal unless until you are sure about your dental map. Most of the time, 95% of the times, you will find the dental map only in 5% of cases where the things are very calcified or where the things are wrong. If properly pulp chamber, if proper SS opening has been made, you will always find the dental map. Read the dental map, try to localize it, and once you know the dental map, it is for sure that you are not going to miss any of those canals.